Hi, everybody. Great to see you. It sounds like we have a very robust crew out there today. And it's a beautiful day, but maybe wait 5 minutes and it'll rain. I don't know. It's hard to tell. Um, this is going to be a wonderful chance to update you on all the goings on in geriatric medicine here at MGH. I realized as I was thinking about this, I don't know where the time goes. I guess you all know this, but it goes by very fast. And I've been here for 4.5 years already. And when I came here, I think there were 4 or 5 docs. And we had our wonderful 3 nurses who, thank God, are still here. And nine other docs that are here now and everything is growing. And so this is going to be a wonderful opportunity to tell you about all the things that we've been doing since we've started to grow our presence here on the inpatient service and outpatient service and throughout the hospital. And so it gives us a great chance to do that. With that, I'm going to turn this over to Judy, who is going to tell you how to listen and fix things if they're not working. And then she'll pass it on to our wonderful medical director, medical director of the Geriatric Medicine Clinic and clinical director of geriatric medicine at MGH. And I'm Sharon Levine. I'm the section head for geriatrics in case some of you don't know me. And I'm very glad to see you all too.
Hello, everyone. I'm Judy Willett. I'm a senior project manager with the division. And my job today is to just remind you, and we've been on Zoom for so many years now, actually, that you probably already know, but you are all muted, and please stay muted because we're recording it. So use the chat function with all your questions, suggestions, anything that you want to know about our primary care practice and all the new innovations and initiatives that we're doing. Please don't share any medical information because everybody can see it in the chat, obviously. And if by any chance, I'm just looking at my little cheat sheet. And you can either watch Dr. Russell, when he's talking, and go on view up in your right-hand corner, and you can both speaker, or if you want to see the whole community of all of us who have joined, feel free to use gallery. So I'll pass it on to Dr. Russell now. Thank you.
Thank you. Good afternoon, everybody. I apologize. I'm on an inpatient service, so I'm in my pajamas, and I have my little virtual background here. I also want to apologize if I start coughing. It is not COVID. It is the air quality and me desiring to be in even more air conditioning. So the reason we're having today's town hall, the main thing we're going to talk about is what's been going on as we've been trying to grow our geriatrics footprint. And just to give you a little background, Mass General is an inpatient 1,000-bed hospital, and with obviously many specialists and subspecialists and subspecialists. And as geriatricians, we're a very small group. But as Dr. Levine likes to say, we are a small but mighty group. And many people would like to see a geriatrician, but as I'm sure those of you in the primary care clinic know, there's only so much that one person can do before they become, their panel becomes full. And so what we've been trying to do as a geriatric section is to maintain our primary care presence and also grow into spaces to help geriatricize the hospital system. And so I'll go into those programs in detail in a few minutes, but that's been our motivation. As Dr. Levine said, when we first got here, we were a very small primary care clinic, did not really have a robust consultation or interaction with other specialists, except for the orthopedics folks, because we do very good collaboration with them. But for the most part, we were sort of off in our own little isolated space. One great thing that happened is that we were able to move from an external clinic to the hospital physical plant. And the reason why that's great is because a lot of our patients need to go to the hospital, need to be seen for procedures, and it's just easier access for us to see our patients when they're admitted to the hospital. Similarly, we can build those relationships with the other specialties and services that take care of older adults, with the goal of making this an age-friendly institution where we start with what matters most to the person to try and design individualized person-centered care that focuses on optimizing someone's functional status, mobility, ensuring their cognitive status is good, mentation, and their medication list. And then again, we always talk about making sure that the guiding principles that the patient expresses are the things that drive their care. So to that end, one of the first programs we started when we made this pivot was our POSH program. Now, POSH stands for Preoperative Optimization of Senior Health Patients. This is a service where we partner with the anesthesiologists and the surgeons. We do in geriatrics a comprehensive geriatric assessment for people for whom the surgeon feels they may want to operate. We'll do a comprehensive assessment, make recommendations in an interprofessional meeting, and design what should be done for the patient to make them the best candidate for surgical clearance, what needs to happen in the hospital to keep them safe, i.e. avoiding certain medications and interventions, ensuring mobilization, and then having a robust discussion about what happens after hospitalizations. You've done the surgery, what happens next and what happens next? Because we realize preparation and it is so much better than anticipating the unknown. So we started that program, and the medical director of our POSH program, this was originally a program done at Duke University, and they have kindly helped us replicate that program here. Our medical director is Dr. Masaya Higuchi, whom several of you may have as your primary care doctor. So when he's not being a primary care doctor, he's seeing patients who are going to have surgery. Our POSH team is Dr. Higuchi, Sindura Paluru, who many of you may know is the nurse practitioner, and I also see POSH patients in my consult clinic. The next program that we've started is called the CHIME Clinic. You know, geriatrics love their acronyms. And the CHIME Clinic stands for Cognitive Health and Integrated Memory Evaluation. That is a partnership between Dr. Hanley and Barbara Moskowitz, who several of you may know was the social worker in our clinic years ago, and she does work with the Dementia Caregiver Support Group and the Memory Care Initiative. So she is an absolutely fantastic resource who partners with Dr. Hanley. Now, what that clinic does is sometimes when we see patients in the hospital or friends and family members notice a loved one starting to have memory problems, but they're not sure how to go about having this evaluated. We send those patients to Dr. Hanley and Barbara to our CHIME Clinic for a full geriatric assessment with a focus on memory and caregiver support. Because the journey of cognitive impairment and dementia is not just a one-person show. It really requires the input and assistance and an education of the people that surround the affected person. We also have our doctors are embedded in some subspecialty programs. For example, Dr. Warren Backman is embedded in the Advanced Heart Failure Clinic. He is seeing patients who have advanced heart disease and frailty and helps to make decisions around optimizing medications and care, and also bringing into focus what's the best way for us to move forward in caring for the patient recognizing that it isn't just the heart that's being impacted. He's a very busy doctor over there in cardiology, and he is also doing work with the amyloid group, which is a subset of advanced heart failure that is can be quite debilitating. Excuse me, I told you it would happen. I did give you the warning. And he's been really doing great work with that, with the hope of having him publish some of his research. Dr. Deborah Lee is embedded in 2 of our community health centers, one in Chelsea and one in Charlestown. So she sees patients 1 to 2 times a month at those locations. And she sees the patients of the practice in Charlestown and Chelsea. And that's a way of geriatrics going out into the community health centers and not only helping educate patients and families about geriatric principles, but also primary care providers in those locations. Lastly, we have on the outpatient service, the Age Positively program. So this is something that I am working with the infectious disease doctors here at Mass General in caring for people living with HIV. People with HIV can experience geriatric syndromes like frailty and falls, being on too many medications, up to 20 years earlier than the general population. So I see people with HIV aged 50 and over, and I do a geriatrics assessment and partner with their infectious disease doctor and sometimes a primary care doctor to make sure that we're providing aligned care, that the left hand knows what the right hand is doing, and that we're really being able to help this person stay functional and cognitively intact as long as possible. So that's our current outpatient offerings. Coming soon, don't have a date on this yet, so it's a teaser, we will be doing group visits. And if any of you have ever done group visits, this is a great opportunity to work with a doctor and also a group of people with the same concerns around how to manage a disease. So you may have heard people who have diabetes going to group visits where they learn about foods they can eat, how to manage their blood sugars, how to take certain medications. It's facilitated by a physician, and other people are attending to get some education, and then each person gets their own time with the provider as well. Dr. Deborah Lee is spearheading that program, and we're hoping that that will go live sometime in the fall. Some topics that we're going to be looking into include bone health, nutrition, and mobility. Our inpatient service. So I'm now switching. We have had for the past 10 years our Geriatrics inpatient fracture trauma service. Stands for GIFTS. What that is older adults who have a trauma event and fall with fractures are seen by their surgeon and taken care of from a surgical standpoint, but we as geriatricians follow that patient during the course of their hospital stay for their medical conditions and to help anticipate and manage geriatric syndromes that can arise. The most common one that we are most concerned about is a thing called delirium. If you or a loved one have ever been in the hospital and has become acutely confused, that is not an uncommon event in a medically complex person. And keeping the patient safe, keeping the patient engaged in their care, mobilized, takes a lot of education of the patient, the family, and the staff surrounding. How do I speak to my loved one when they're delirious? How does the delirious person come out of delirium? What do the staff need to do to recognize, prevent, and manage it? So we've been doing that for 10 years. Many of us who work in the clinic have taken an interest in helping expand the geriatrics footprint on the inpatient service. Again, this is a 1,000-bed hospital. The average age of a hospitalized patient is in the high 60s to low 70s. So it is very much a geriatrics hospital in terms of the patient population we serve. That doesn't mean we are doing the geriatric care in the exact way that we are hoping to get to. And that is our initiative that we're working with. Dr. Levine is spearheading the Age-Friendly Health Initiative to make sure that every part of this hospital is striving to meet the needs of the older adult population. It is pretty obvious from population trends that that a hospitalized patient is more likely to be an older adult than not. So we need to design and constantly improve on our system so that we are meeting that need. So moving on from that, we also have the Geriatric Surgery Verification Program. Many surgeons in this hospital recognize the population trend and the need to be more proactive in caring for an older adult. And so we have a Geriatric Surgery Verification Program, and Geriatrics is participating in helping that come about. The goal is to focus initially on what is most important to the patient. What are they hoping to achieve with this? They are to have a geriatrics evaluation and assessment. They are to be followed as much as possible by geriatrics. Now, 5 doctors and 3 nurse practitioners can't cover a 1,000-bed hospital. And so we're doing this in staged growth. Right now, we are seeing patients not only on the inpatient fracture trauma service, but also anyone who's gone through our outpatient POSH program who has the surgery at Mass General, we are following. So that patient has a geriatrician. Additionally, patients who come in through other surgical services are also can have the chance to have us weigh in and follow along with the patient's care. So far, that is about 2 months old, and the initial reviews are very positive. What we are finding as the providers is that this is very much not only about the medical care that we're providing to a patient, but also helping upskill the inpatient staff in caring for older adults. With COVID, many experienced nurses and other health professionals left the field. And so we have an opportunity to meet with and teach new clinicians in getting sensitized to the unique needs of this population, including mobilization, ensuring that someone has their hearing aids and glasses, making sure that there are not barriers to effective communication, and making sure that family and patient goals are clearly elucidated. So that's the programs where we're at right now. What are our limitations? Personnel, personnel, personnel. We all would like to be in 10 different places at once if we could. But that is why our growth has been slow, because we haven't been able to grow our team. That is always a goal for us. There is obviously the financial reality of recovering from COVID and the hospital focusing on priorities that are, equally as important. We recognize that access issues are a problem for primary care in geriatrics. If you have adult children or friends who are outside of the system, who do not have a primary care doctor, this is not a problem unique to Mass General. Most hospital systems have seen an exodus of primary care providers And so we are in geriatrics experiencing a lot of people wanting to join our practice because their former primary care doctor has decided to retire or leave the field. And so we have a significant backlog of people and a wait list. I wish that wait list could move quickly. And we are certainly working on making availability a priority for our patients who are currently established with our practice. I think that was all I had, but if Sharon or Judy, if there was anything I left out, I wrote it down, but as a doctor, I can't read my own writing. So thank goodness for typing.
Well, I also wanted to mention that we are part of the division. Geriatric medicine is a section in the division of palliative care and geriatric medicine. And we also have a research presence in the areas of geriatric medicine and palliative care medicine, and particularly around serious illness, aging and serious illness, which is run by Dr. Christine Ritchie, who has a whole gang that she's got working on research projects. So if anybody ever wants to be involved in research and we're looking, please let us know, because we love to have people. Some of it is just talking about stuff. Some of it may be about caregiving in the community. And the other thing that we're doing is education. We're educating physicians in training. We are educating our colleagues. We are working with physical therapists and nurses and occupational therapists, trying to geriatricize everybody in this institution who comes across with older adults, and particularly around patients who are living with dementia and other serious illnesses, but particularly living with dementia, because Massachusetts has legislation which says that we have to be able to take care of those patients and do it well. And who better than to train everybody else in the hospital? There's a whole lot of people in this hospital that work here about how to provide the best care for our patients who are inpatients and outpatients. So we are working in doing education, not only of doctors and doctors in training, medical students, but nurses in training, PAs, and others who are training at the Mass General Institute for the Health Professions. Our nurses are training nurses and PAs and others in the Institute for Health Professions. So there's a whole lot of education that's going on that it really takes a village. If you want to geriatricize, put it in quotation marks, a medical center in a big 1,000-bed hospital, but also gigantic outpatient presence. This is part of us being small but mighty. We are stretched across that entire universe and are teaching people on the inpatient service how to mobilize people to prevent the dreaded delirium that Matt was talking about, which is the acute confusion that often happens when people are in an unfamiliar environment, especially people who have underlying problems with their memories. We really take this very seriously. So it's not only our care of people, but it's training. You probably don't know this, but I'll tell you, there are only 7,000 geriatricians in America. I want you to think about that. There are 7,000 board-certified geriatricians in America. Only 2.5% of people graduating from residency programs this year went into geriatrics. So we are small and we are mighty, and we have a large task. We are not, we're like rubber bands. We stretch out as far as we can and take you in with us and teach our colleagues how to do that too. I guess those are the other things that I wanted to make sure that I told you guys that we do, because not only do we see patients, we teach others how to do what we do. We have 2 new fellows starting.
I was just about to say, at this time of year, we for those of you who have worked with our geriatric fellows, they have graduated this past Tuesday, and we will be having 2 new geriatric fellows. So Dr. Lum, Dr. Catherine Lum, who was with us for the past year, is actually staying on. She'll be working part-time on our inpatient geriatric service, and she'll also be a doctor on the hospital at home program. This is the alternative to being on inpatient in the physical hospital and just being on your inpatient in your living room, which in some conditions really is great, because as much as we love to see our patients, we totally understand being in the hospital is not the place they'd like to be if there was another option. Dr. Lindsay Barker is going on to a career in geriatrics at UMass Medical School out in Worcester, my alma mater. So I don't feel like I'm losing her at all. It's just adding to the wonderful institution that UMass is out there. Dr. Olivia Aronson, who was our fellow last year, stayed on for a second year to do research, and she's actually going to be returning to her home state of Arkansas, and she'll be working at the Little Rock VA hospital, and she will be an amazing addition to that group. For those of you who have met Julia Gallagher, she was our fourth fellow. She is a palliative care doctor and did her fellowship with us, which finished in December. And she is staying on as well in geriatrics and also at hospital at home, and she'll be working in our inpatient site. So I just wanted to, this is that sort of state of the state or state of the clinic that we always like to share with our patients about where we're going and how we're growing. And as always, if there's an area or a field where you feel, hey, would geriatrics look into this? We are a very interested group, and if it can be something that we can add and find an expert to come and work with us on, I think we'd be more than happy to oblige.
Matt, there's a question in the chat.
Okay.
If you want to change your PCP but stay within geriatric medicine, is it possible because of the long wait list?
I don't see the question.
Oh, did you hear?
Sorry, if the question was if you are in geriatrics.
You're already a geriatric medicine patient and you want to change your PCP, but stay within geriatric medicine. Can you do that?
What I always will tell people to do is usually we do not switch providers within a year. And many times people are interested in switching because the chemistry isn't right. We all allow for that. Sometimes it can be because the doctor isn't giving me the answer I want. And I think it's really important for us to be able to understand the reason why the switch is desired. Because if it's just a chemistry thing, that's fine. But if it is something a little bit more, we'll probably get the same answer from another doctor in our practice. I usually encourage people to stay with that provider. We have the ability to switch our patients around. All of our providers have completely full panels. So in order for somebody else to take on a patient, that means that that provider taking on the patient would have to give up another. And I'm sure you understand that when I have my patients, they're my patients. I don't give them up. I don't want to give them up. They're mine. And if they want to leave me, that's another thing. I can't help that. But I would very much say that it requires a lot of behind the scenes moving to be fair to everyone. And then sometimes when the chemistry isn't right, it's an opportunity for me as the medical director to hear from the patient and to also provide that provider with some feedback, because we don't call it perfection, we call it practice. Many of us have had encounters with patients that didn't go as we wanted. That doesn't mean we're horrible people or bad doctors. It just means we still need to learn.
We are also, you may notice this, you get to see our wonderful, fantastic stupendous. And I know some of you out there who told me these things, nurse practitioners who work here. And some of you only want to see our nurse practitioners because they're so fabulous. They are part of our teams. We work very closely with them because we cannot be cloned. It's totally impossible yet in medical science to clone ourselves. But we really love it. When people come the first time, we really want you to know that we share our patients to make ourselves stretch further than we can. And some of you sort of glom on to our nurse practitioners because they're so just I'd go to any single one of them for anything. They are just incredibly fabulous clinicians. And I'm sure a lot of you would corroborate that. And same as ditto for our patient support people, Erin and Deb Shuda and Leona and Jody and the people who you interact with over the phone a lot, not to mention our fabulous medical assistants. So, but definitely our nurse practitioners really allow us to expand our presence. And that's a really important thing for you to know and to enjoy, I would say. I would go to any one of them myself, and I would send anybody in my family to any of those folks.
Absolutely, completely ditto.
Another comment in the chat is that Jean Cronin says, available to volunteer, lots to share, please contact me. So maybe Emily could contact Eugene and see what you're thinking of for volunteering, because the hospital has a very large volunteer organization. So, and now Matt, do you see the next?
Yes, I do. I think I just want to say to Jean, thank you so much. This is wonderful. You know, one thing that that I know about from COVID and also doing my age positively work is that isolation, loneliness, and having a very close relationship with the people in the clinic is very important. Those are all very much at play for a lot of our patients. And I would love our waiting room to be a living room where people can come and visit and socialize. Don't come and do that yet because I have to propose the program. But I think that it's oftentimes there's, people are in the hospital for this test and that test, and just having some connection in place. And if there's a volunteer there to be able to just chat and shoot the breeze, I do think it just makes those miserable days in the hospital, schlepping back and forth, so much better. The next question is, my dad specialized in geriatric medicine, long-standing in complex patient. Yeah, so we actually have a geriatrics consult clinic. So all of us are able to see patients. They don't have to be part of those special programs that we're talking about. You can just call up our clinic and get an order from your dad's doctor for a geriatrics assessment, and then we can do that. A lot of geriatricians who practice in primary care actually don't have the bandwidth to do a full comprehensive geriatric assessment because they're operating in a primary care model. So just restating what Dr. Levine was saying, in geriatrics, you're not just cared for by your doctor. Definitely not. And nor do you just want only your doctor taking care of you. The triage nurses that you speak to, they're in your chart. They are knowing your story. They are communicating with our nurse practitioners. Our nurse practitioners are partnering with us because if I miss something in a patient, one of my partners can come and see that or offer a unique perspective, like Emily, our social worker. She'll come and say, this isn't actually a medical and pain issue. This is someone who's really scared of being alone for fear that something is going to happen to them. So we have a wonderful, amazing interprofessional team, and we have built into our system the ability to do hour-long visits for new patients, half-hour visits for established patients, and hour-and-a-half visits for our consults.
Matt, can I just answer one other thing for Kelly? We can, if a primary care doc is, anybody who has primary care knows you're in and out. Send somebody to us. We can co-manage patients with the primary care doctor. So what I will often say is, and there's a lot of good primary care doctors here, but it's just too much to handle in one appointment. You could do it in serial appointments, but sometimes I will say, I'm happy to co-manage you with your primary care doc. I will write back to the primary care doc and say, I'm happy to co-manage Mrs. or Mr. So-and-so, and I'll see them twice a year or 3 times a year. And we always talk with all of the docs we work with, whether we work with primary care docs in general medicine here, or whether we work with cardiologists or gastroenterologists. We are part of that team. So we, just so you know, we sort of love to stay in contact with people. And actually, it's our experience that these other specialties and also the primary care doctors really appreciate our input, because they just don't have that's why they don't have the training about geriatrics, and nor do they have the bandwidth when they're seeing so many patients. So, Kelly, if your dad, if your dad's PCP can send your dad here as a consult patient, we would see your dad and work with his PCP. We can do that.
And again, if you are interested in a geriatrics consult, we don't need an insurance referral, but we do need a physician's order from the primary care. And that is because a lot of the recommendations, anytime you do a consult, you're giving recommendations. Yes, we're going to give some to the patient, perhaps the family, but we'll also be giving recommendations to the referring provider. And so we need someone to hand off to that. Do folks have other questions before I move to the beautiful poem? So I get to use this last moment to brag about a student that we had, a Harvard medical student that we had for the past, I'd say it was it was over a year. She joined a small group of patients, and Emily, our social worker, and me. And when we met, she read her poetry. And she's now graduated and has just started her residency in internal medicine at Stanford out in California. Her parting gift to us that we're hopefully going to have framed in our clinic, I'm going to share with you. And I think it really captures the spirit of geriatrics, exactly what it is that we are trying to do in helping people continue to enjoy and live their life to the fullest. So with that, I'm going to share my screen. And I'll see if I can do this. And then I'm going to, are you looking at the big picture now? Is this correct?
Looks great.
All right. So I'll just read it. Tell me about the last time you saw a bumblebee, not a honeybee or a wasp. Tell me about the last time you rolled down a hill without worrying about breaking your back, hips, or heart. Tell me about the last time you skipped, like really skipped down the street, because who cared who saw you or where you were? It only mattered you felt joy in that moment, manifesting into your leaps and gallops. Tell me when you last touched grass to make a flower crown, or see if you liked butter, or blow dandelion seeds into the wind without worrying about allergies or dirt beneath your nails, or the list of tasks you still had to do. Tell me about the last time you did this or that. But can you remember the first time? How gleeful it felt to know that the earth was yours for the taking. Let me tell you this, that it still is. It still is. It still is. My hope is that that poem will be on our waiting room wall, because it really, I don't cry easily, but it definitely touched a nerve there in a good way. And so with that, we don't have as full an agenda this month as we will in future months. Next month, we're probably going to be talking about a concept for polypharmacy. Poly meaning many, pharmacy meaning medications. Not just being on many medications, but am I on the right medicines? And what do I need to know about who prescribes them, who should prescribe them? How do I keep them all straight? Finances, all of that. So that's a little bit of teaser for next month. Thank you all for joining this gray, weird day of Canada smoke. And enjoy your summer, and hopefully, and have a lovely July 4th holiday. And we'll see you later in July.